This lecture is about the salivary gland pathology. We are going to discuss in this lecture about malignant salivary gland tumors, and the main way in which benign and malignant lesions are differentiated is by three important entities. First is the rate of growth. The malignant tumors are very fast. They double up in maybe 14 to 15 days. And during this rate of growth, the cells are not contained by the surrounding capsule, which leads to invasion. And the invaded salivary gland tissue make it get fixed to the underlying muscle, nerves, and the fascia. And this growth is irregular in nature, giving rise to the nodular appearance. So a pleomorphic adenoma may be uniform globular mass, whereas mucoepidermoid carcinoma will show lobulated appearance. Histologically also, there is extension into the capsule and it may spread further down from the capsule to other places, leading to metastasis. Histologically, the cells also are a little more atypical, giving rise to pleomorphism and high rate of mitosis. The classification as adapted from Regesi, you have the classification as benign and malignant tumors. The benign tumors mainly include pleomorphic adenoma, monomorphic adenoma, oncocytic tumors, sebaceous adenoma, and ductal papillomas. When it comes to malignant salivary gland tumors, the most common malignant salivary gland tumor is the mucoepidermoid carcinoma, followed by adenoid cystic carcinoma and acinic cell carcinoma. There are other variants which include clear cell carcinoma, PLGA, presently called as polymorphous adenocarcinoma. The term low grade has been removed in the recent classification. When you do not have an ability to classify it, we call it as adenocarcinoma not otherwise specified. Other than these, there are malignant salivary gland tumors, which are predominantly associated with parotid tumors like carcinoma ex pleomorphic adenoma, epithelial myoepithelial carcinoma, salivary duct carcinoma, basal cell adenocarcinoma, oncocytic adenocarcinoma, sebaceous adenocarcinoma, and squamous cell carcinoma. In this lecture, we will concentrate on the three most important salivary gland tumors: the mucoepidermoid, adenoid cystic, and acinic cell carcinoma. Mucoepidermoid carcinoma, as the name suggests, it has mucous cells and epidermoid cells, hence the name mucoepidermoid carcinoma. If you look at the clinical picture here, you can see that there is a lesion on the tongue and it is not uniformly lobular, and there seems to be a globular appearance over there. When you look at the histological picture here, you can see some clear cells, which may be the mucus counterpart, and then you have cells which are forming solid sheets, which are the predominantly epidermoid components. As said before, this is the most common salivary gland malignancy, and it occurs in the age group of 30 to 70 years, slight female predilection, usually seen as an asymptomatic swelling. So you can see the image of the palate there, maybe less than 3 centimeter in size. And parotid seems to be more involved, followed by the palatal region. The minor salivary gland tumors usually appear as a swelling which may be fluctuant and have a characteristic bluish color, which can be mistaken for a mucocele. These tumors may also occur in sites where few minor salivary glands are present, like in this case of the glands of Blandin and Nunn have given rise to mucoepidermoid carcinoma. Mucoepidermoid carcinoma can also arise from odontogenic epithelium, which are entrapped inside the bone. So there is an intraosseous variant of mucoepidermoid carcinoma, and the entrapped cell rests have the capability of differentiating into mucous cells, which can give rise to mucoepidermoid carcinoma. Histologically, there are three basic types. Type 1 cell is the mucous cells, which are typically polygonal in shape. The nucleus is pushed towards the periphery, and there will be clear cytoplasm there. Sometimes the cytoplasm may be flocculent, giving rise to a multilocular appearance. Then you have the epidermoid cells. The epidermoid cells resemble that of a squamous cell. They are polygonal, hyperchromatic, centrally placed nucleus, and an abundant cytoplasm. An intermediate cell is something like an epidermoid cell, but is more basaloid. Basaloid means the nucleus is much bigger compared to the size of the cytoplasm. So there will be a thin rim of cytoplasm sitting around each of these nucleus. So these are the three basic cell types. So which is the best cell? Mucoepidermoid carcinoma itself is a bad tumor, but if you have a tumor which is predominant in mucous cells, they are considered to be of better prognosis than that of epidermoid cells. So when you look at a tumor, they are not predominantly of one type. There is always a mixture of mucous, epidermoid, and intermediate cells as seen in this figure. So here if you look at the lobulated area here you see predominance of mucous cells, whereas other areas here you see epidermoid cells. So a combination of mucous, epidermoid, and intermediate cells gives rise to clumps of tumor cells which are not restricted by the connective tissue. So it's usually unencapsulated mass. And they keep growing. And the mucous cells may also vary in shape and contain abundant foamy cytoplasm like this, which are stained positively with mucin stains like mucicarbon. The intermediate cells, on the other hand, they are basaloid in appearance. The word basaloid comes from the basal cells of the surface epithelium. So if you pick up any of these cells, you can see that each of this nucleus is surrounded by a thin rim of cytoplasm. This big cell with a large area of cytoplasm may be a variant of an epidermoid cell, but overall this particular region shows predominantly cells which contain intermediate category. Maybe these clear cells here may be a variant of the mucous cells. You can also appreciate some cells which are showing mitotic activity. This is an area where you see predominantly squamoid features. They are polygonal shaped cells with prominent intercellular bridges. So each of these cells you can see are stretched out together, and these are the epidermoid cells. So now that you know there are three types of cells, based upon the arrangement of these cells and based upon the quantity of these cells, you have three different types. Sometimes the clear cells may also lack mucin positivity. So they are characterized as clear cells and usually associated with lymphoid aggregate, and there is a separate variant of mucoepidermoid carcinoma called as clear cell variant of mucoepidermoid carcinoma, which is known to metastasize very easily to distant sites. So based upon the arrangement, we have three categories. One which have lot of cystic spaces. The other which has very low degree of atypia and very low number of mucous cells. So based upon the amount of cyst, amount of atypia, and the number of mucous epidermoid or intermediate cells, it is categorized as low grade, intermediate grade, and high grade mucoepidermoid carcinoma. Mucoepidermoid carcinoma of the low grade will show large cystic spaces as you see here. This is a very large cystic space filled up with some mucin and some inflammatory cells inside. And then here also you can see three cystic spaces. Of course, there are some intermediate and epidermoid cells, but when you look at the whole field, you can see that there are large cystic spaces. And when you zoom into a higher power, you may not find much of mitotic activity, pleomorphism, increased nuclear cytoplasmic ratio, etc. The high proportion of mucous cells, low level of atypia, and prominent cyst formation will classify such a tumor as a low-grade mucoepidermoid carcinoma. In contrast, a high-grade mucoepidermoid carcinoma will not show any cystic spaces. And if you zoom into the cells, you can see a metaphase Here, a very hyperchromatic nucleus. There is pleomorphism. Some nuclei are small, some are large and hyperchromatic. There is lot of cohesion loss seen around. So these are the features which give rise to an indication and look similar to that of squamous cell carcinoma. There will be very few mucus producing cells. These types of tumors would be categorized as high grade tumor. Once we know what is low grade and high grade, anything in between will be categorized as intermediate grade tumor. There will be 50-50 percentage distribution of cystic and solid spaces. There may be some areas of atypia, and all the three cell types are present when, but it becomes difficult for the pathologist to actually identify which is more predominant, and maybe you will say that the intermediate type of cells predominate. So at this juncture, a pathologist will categorize them as an intermediate grade tumor. To bring about a little more objectivity to such a grading system, there are grading systems proposed by Auclair as well as by Brandwein. So in this particular system, you can see that the intracystic component, if it is less than 20%, you give a score of 2. If there is neural invasion present, you give a score of 2 again. You will be able to make out these mucous, epidermoid and intermediate cells invading the nerves. If there is necrosis present, it's a bad sign. We give a score of 3. If you have 4 or more mitotic cells in 10 high power fields, we give a score of 3. If there is anaplasia present, where you are not able to identify what type of cell it is, we give a score of 4. So when you add up all of these, if the score is less than or equal to 4, you classify it as low grade tumor, 5 to 6 as intermediate grade, 7 to 14 as high grade tumor. Whatever be it, mucoepidermoid carcinoma does not have very good prognosis when it occurs in the major salivary glands. Treatment is basically excision of the gland, and you may have to follow it up. If there is extension metastasis, you may have to undergo chemoradiotherapy. So this is about mucoepidermoid carcinoma. The next malignant salivary gland tumor is adenoid cystic carcinoma. Earlier, it used to be called as cylindroma, but the term cylindroma is not used anymore. The cylindroma term was used for a skin appendage tumor which has very similar histological presentation as adenoid cystic carcinoma, but it is totally a different clinical entity with a different kind of prognosis. So now the term cylindroma is not used. We use the term adenoid cystic carcinoma. The clinical features include pain in a early time, because adenoid cystic carcinoma is notorious to show invasion into the nerve tumors. It constitutes only 10% of the salivary gland tumors and is the most common salivary gland tumor of the submandibular salivary gland. Occurs more than 40 years of age and there's no specific gender predilection. Now look at this person here. You can appreciate that there is an asymmetry there. Even though she is smiling, you can see that her right side seems to be paralyzed, which is sometimes because of the involvement of the facial nerve when the parotid gland is involved. The same person also had a palatal lesion here, and you can see there is an ulceration that develops in this. Adenoid cystic carcinoma is notorious to show metastasis at an early stage. The palatal tumors are usually smooth surfaced, but may easily ulcerate, giving rise to an ulcerated mass in the palate. They may invade the hard palate. You can see a lot of bone loss in the radiograph. And histologically, it is made up of a mix of myoepithelial cells as well as the ductal cells. There are 3 major patterns that are described in adenoid cystic carcinoma. The first pattern is a cribriform pattern, which is also called the classic pattern. The second type is the tubular pattern, and is intermediate between the solid and the cribriform types. The solid is the worst prognosis, and there is no cystic component in that. Whatever be it, based upon whichever type is predominant in a histology, we give that tumor that particular classification. So we basically, when we get the whole of parotid, we take around 20 to 30 different sites and sample it out so that we will identify which is the major type, as prognostically they are different from each other. When you look at a cribriform type, it is the classic type, also called as the Swiss cheese pattern. So if you look at this particular entity here, there are zones of lobular masses, and these lobular masses are separated by fibrous septate. And within these lobules, you see cells which are growing in small cystic spaces. A large mass separated into multiple small cystic spaces, something like the cribriform, that is perforated plate. So hence the term cribriform plate or the cribriform pattern. The tubular entity, on the other hand, you can see ducts. So you have small oval or round ductal spaces with empty spaces that may or may not be filled with mucin. On the other hand, the solid variety is something like this, where you do not see much of a cystic space. Although there is a large cystic space here, predominantly the area is solid in nature. So I would like you to look at the color of these particular cells. These cells are hypochromatic, and you can see that very less of eosinophilic matter is seen all around. This shows that these cells are predominantly baseloid, and they are rich in nuclear content than the cytoplasmic content. Let's have a look at the cribriform pattern. As discussed, the cribriform pattern looks like the Swiss cheese pattern, where you have perforated cheese structures, also called as the sieve-like appearance or honeycomb-like appearance. These are typically characterized by baseloid cells or islands, which are perforated by cylindric cyst-like spaces, like this. The cribriform pattern is usually lined by two cells. So you can see each of these cystic spaces are lined by two cells with very less amount of cytoplasm, prominent oval or round angulated nuclei. The nuclear cytoplasmic ratio is roughly 1:1, which is similar to the basal cells of the epithelium, hence the name baseloid cells. So you can see further smaller cribriform, and you can also appreciate the cystic spaces are filled by mucus. These mucous materials are nothing but glycosaminoglycans that are incorporated into the cystic spaces. Sometimes the tumor are surrounded by a very nice hyalinized stroma. This is because of the inductive effect. These cells are able to stimulate the connective tissue to deposit fibrous stroma. It is mainly an activity of the myoepithelial cells that are surrounding these islands. The tubular pattern is the next most common pattern, which accounts for only 20 to 30% of the cases. They are lined by one or several cells, and the inner layer is usually eosinophilic and the outer layer is usually baseloid, which represents the myoepithelial cells. The cribriform structures are seen in the bottom, and there are tubular structures seen on the top of this particular figure. These are solid areas which account for less than 15% of the cases. There is absolutely no cystic formation. They will be a more aggressive kind of tumor. These are predominantly baseloid cells, and because of the solid areas, the central areas of large islands may undergo necrosis. Another important feature about adenoid cystic carcinoma is the presence of perineural invasion. You can see the central area shows the nerve axon, and the tumor typically shows a attraction towards these neural structures. It is said that the nerve growth factor, which is produced by the adenoid cystic carcinoma cells, attracts the nerves to grow towards the tumor. So whether it is tumor going towards the nerve or nerve coming towards the tumor, histologically we appreciate a perineural invasion. This perineural invasion is the reason for high rates of metastasis, as the tumor cells can pass through the axon, through the peripheral nerve sheath, and invade distant sites. Adenoid cystic carcinoma, like mucoepidermoid carcinoma, has to be surgically excised. Most of the time, when solid variants are there, adjunct radiation therapy is usually given. They are prone to high chances of local recurrence and may metastasize more frequently than the other types of tumors. Another tumor that is notorious to be misdiagnosed is the acinic cell carcinoma. And when we talk about salivary gland, the salivary gland acini are basically divided into two entities, a mucus acini and a serous acini, although they do occur together. Whenever you look at a serous acini, they are more granular because they contain zymogen granules, which are rich in the amylase enzymes that are required for digestion. These zymogen granules or enzyme generating granules are noted in acinic cell carcinoma cells, and hence the name acinic cell carcinoma. This is the second most common parotid tumor and the second most common pediatric malignancy. Occurs in roughly the 5th decade, and parotid is of course the most common tumor. Like any other tumor, females are more likely affected, and it also shows bilateral parotid disease, although less common than Warthin tumor. Usually seen as a single slow growing mass, and it is notorious to invade around the nerves, so usually a painless mass. Histologically, you see a very well circumscribed encapsulated mass characteristic of serous acinar-like tumor cells. So how do you identify a serous cell? You see a polygonal cell with the nucleus pushed towards one end, but still round, not compressed as it happens in mucus cells. And the cytoplasm is richly granular. They may be basophilic or eosinophilic, but they are granular. They are fairly uniform, and they are usually end cells. They do not show mitotic activity. Based upon the arrangement of these cells, they may be classified as solid, as it says solid areas, microcystic, as it says you'll see cystic areas, and these cystic areas may show projections, papillary projections, so papillary cystic, and then it may resemble a thyroid nodule, so it is also called as follicular type of acinic cell carcinoma. The most common type is, however, the solid sheets, and the solid and the microcystic may occur together, as you can see here, solid areas and a microcystic area here. Small dark eccentric nucleus. So let's have a look at this. You have a dark eccentric nucleus present, and there will be basophilic granules seen all around. The key feature that you should appreciate is when you see a acinic cell carcinoma, it looks very much like a serous salivary gland. But the normal salivary gland usually is associated with striated ducts, intercalated ducts, and excretory ducts. You do not see these striated ducts. That gives an indication that it may be an acinic cell carcinoma. Complete local excision followed by some amount of chemoradiotherapy if metastasis is noted. So these are the three most important malignant salivary gland tumors. One entity which finds its way to the differential diagnosis of not only these three malignant salivary gland tumors, but also squamous cell carcinoma is necrotizing sialometaplasia. As the name suggests, you will find necrosis of the tissue where it is occurring, and you will get metaplasia. Sialo means salivary gland, and the salivary gland tissues metastasize into, they metaplastically change themselves into squamous cells, and it looks histologically also like squamous cell carcinoma. It is a locally destructive inflammatory condition, and as you see here, there is a big ulcer which gets, it can also cause porosity in the bone, and it mimics the malignant process of squamous cell carcinoma, not only clinically but also microscopically. The main reason is ischemia. The salivary gland tissue suddenly loses its blood supply, which leads to local infarction. And there are multiple reasons quoted: trauma, dental infections, ill-fitting dentures, previous surgery, herpetic infection. However, we do not know the exact cause of it. Whatever be it, usually it occurs in the palate. 75% of the cases occur in the palate, and 2 to 3 cases are unilateral. Rest of them, that means 2 out of 3 cases, are seen in one side, but sometimes it may cross the midline. Usually seen as a swelling initially, then suddenly it will ulcerate. And the mean age of occurrence is around 40 to 50 years of age, and males are more likely. And it is associated for unknown reasons with smoking. There will be numbness and referred pain with burning sensation seen with necrotizing sialometaplasia. The two key histological features include the necrosis of the salivary gland tissue with the lobular architecture maintained. That means, if you remember in adenoid cystic carcinoma, we saw the lobulated pattern. The central portion of the lobules will suddenly disappear. So you will just have a skeleton of the fibrous tissue around. Second important feature, you will not see salivary gland acini and ducts, but instead you will see squamous metaplasia. So let's have a look at it. So you can see a lobular pattern. You can see there is an outline over here, but the central area shows necrosis. Second important feature, you can see islands, squamous islands, and there may be foamy macrophages associated. The surface epithelium reacts by proliferating, giving rise to islands, and this resembles that of a squamous cell carcinoma, hence the name pseudoepitheliomatous hyperplasia. It resembles squamous cell carcinoma invading into the connective tissue, but in reality it is reaction of the surface epithelium to the underlying entity. Here further, more islands that you see. It can have some clear cells which resemble necrosis, and we did discuss about necrosis in mucoepidermoid carcinoma, so may be misdiagnosed as mucoepidermoid carcinoma. Usually you take a biopsy to rule out malignancy. After the diagnosis, the lesion does not require any treatment and heals within 5 to 6 weeks. So it's an important differential diagnosis for squamous cell carcinoma as well as malignant salivary gland tumor. So in this lecture, we discussed about the 3 important salivary gland malignancies: mucoepidermoid, adenoid cystic carcinoma, and acinic cell carcinoma. And we discussed about necrotizing sialometaplasia, which is the most common differential diagnosis, which may mimic clinically as well as histologically as squamous cell carcinoma and malignant salivary gland tumors.